Our topic is surgical caveats in vitreoretinal interface disorder management.
And
Dr.
Play the
Kshitiz
slide,
Kumar.
please.
and we have to stick to our time, only 7 minutes,
The
because we
slide
have
is
to
not
wind
getting
up.
displayed.
7 minutes, please.
Yeah, I'll
we have
try
to
to.
because
A very
we
good
have
morning
to
to
hand
all.
over the.
A very good morning to my esteemed panelists and everyone from AIOC who is here. So my topic is surgical caveats in vitreoretinal interface disorders management. So I would be basically discussing about the vitreomacular traction syndrome, epiretinal membrane and disorganized retinal inner layers and lamellar macular hole. I am skipping the macular hole component because itself is a big entity to discuss. So vitreomacular traction syndrome forms a part of the spectrum of diseases with abnormal vitreomacular adhesion. And basically there's an anomalous posterior vitreous detachment accompanied by anatomic distortion of the fovea, and the symptoms could be none. They could be distortion or they could be a reduced visual acuity, and this group classified the vitreomacular interface. Mainly they classified the vitreomacular adhesion, VMT, and the full thickness macular hole. So if we look here, this is a case of a vitreomacular adhesion, and if the area, and we can see that the area of this anomalous detachment is less than 1500 microns, so it becomes a focal one. Again, another example of a focal vitreomacular adhesion. It's a concurrent one because there's a underlying drusen also. Now this is a case of a broad VMTS where the anomalous detachment is more than 1500 microns. So what happens in a vitreomacular traction syndrome, that the foveal anatomy undergoes some distortion, and it can be associated with a epiretinal membrane, and it becomes a broad VMT. And so what if we don't operate vitreomacular traction? So what happens in this study? They showed that 60% would persist, 20% generally resolves. In their study, it resolved in almost 15 months. However, the 12% progressed to full thickness macular hole formation, and 8% had elected for the surgery. So in a case of persistent vitreomacular traction syndrome, the vision may be normal, but with this background, we know that it may progress to a full thickness macular hole. And the same thing we also concluded, we found in our paper that in eyes with full thickness macular hole, the other eye would be having vitreomacular traction in almost 10% of the cases. So now when you're observing a vitreomacular traction, so what happens over the years, you would see these schisis-like spaces forming inside the retina, and eventually it may progress to a full thickness macular hole. And some example of a vitreomacular traction in case of a diabetic, where we can see a neurosensory detachment with a schisis-like spaces forming inside the retina. And coming on to the surgery, so it starts with the trichot-assisted vitrectomy. Then once the trichot goes in, you see that large amount of trichot gets collected at the posterior pole, and then you suck out the excess of the trichot before you start attempting the PVD, else you may touch up the retina. And then you do this gentle lifting in all directions till you have a good purchase and you lift it towards the ora. So that was a case one. And then it is followed by peeling of the ILM so that the puckering doesn't happen. Coming on to the second case, now in this case there was a broad VMTS, and if there's a vitreomacular traction syndrome and you are not able to lift it in one go, then what happens? You may have breaks and in the periphery, so you should always look for breaks, search for the breaks. As in this case, you would see that there were small holes which had formed. In fact, multiple holes had formed all around. And then what you do is you do the laser. So looking for holes in cases of VMTS is very important, just not eating away the vitreous matters, but also securing the retina. And this was a case where, before attempting the PVD, I should have removed the excess trichot and ended up, touching the retina and creating a break near the peripapillary area. And this is another case of a broad VMTS where you see after the PVD has been completed and the VMTS has been removed, there was a peripheral break. Now you see here there's a flap tear which has formed. So you should be very cautious while doing PVD in cases of VMTS, because you may end up having a break in the periphery. Now coming on to the next entity, which is epiretinal membrane with disorganized retinal inner layer. Now if you see here that there's an epiretinal membrane, and there's some distortion of the anatomy of the fovea. Now whether there is a drill present or not, for that you have to see that this boundary which is forming between the ganglion cell layer and the inner plexiform layer, and the inner nuclear layer and the outer plexiform layer is distinguishable. If it is distinguishable, then there's no drill. In this case, you see that the boundary is not, inner boundary is not distinguishable, but the outer boundary is distinguishable. So it's a case of a mild form of drill. If both the boundaries are not distinguishable, then it becomes a severe form of drill, and it may or may not be associated with disorganized ISOS or ellipsoid zone. So it's a severe drill with a disorganized ISOS zone. Now this is a case of a mild drill, the video of which I am going to show. And we had published this paper, and where we always do a double peeling in cases of epiretinal membrane. That is, first you remove the membrane and then you again stain the ILM also and remove it as well. Now in cases of epiretinal membrane, if you see here that you have to keep on doing this pinch and peel and keep on moving in all directions, suddenly you will feel that in one direction it starts getting lifted off easily. And so once complete thorough removal of the epiretinal membrane has been achieved, then you again go in and stain the ILM, and you will see that the ILM is also puckered. So you should always do a double peel in cases of epiretinal membrane. And now you see the underlying ILM was still intact, it was distorted, so just removing the membrane would not have sufficed. So this was the outcome. Now coming on to the last entity, which is the lamellar macular hole. So as we all know that it's an abortive process, it has a defect which is not a full thickness one, and this diagnostic criteria where the lamellar hole has to have a foveal thinning with irregular contour, breaks in the inner layers of the fovea, intraretinal split, and absence of a full thickness defect. Now, Govetto et al. Classified lamellar macular hole into a tractional one and a degenerative one. So, in a degenerative lamellar macular hole, you will get a membrane which is called lamellar hole associated epiretinal proliferation, as against a tractional lamellar hole where the epiretinal membrane would be thin and you would have these schisis type of cavities. So, the important thing here is to distinguish between a tractional versus a degenerative type of lamellar macular hole, because the approach has to be different.
Dr. Kshitiz, yeah.
So I'll just conclude. For a degenerative lamellar macular hole, you should not do a double peel, because you may end up in having a full thickness macular hole. Whereas if you have a traction lamellar hole, then removing the epiretinal membrane as well as ILM will suffice. Thank you.
What is your opinion, sir, regarding the use of pharmacovigilance?
I have not tried, sir, because that plasmin thing was very expensive, and in cases of VMTS, one may try that.
And what is the incidence of VMT resolving by itself?
So that is what's a 20%.
20. So how much time does it take? I mean,
So
how many months one can wait for that?
So that study showed in a follow-up duration of 15 months, 20% cases had resolved, 60% persisted. Thank you.